Okay, it looks like we are ready to get started. Many thanks to everyone for joining us for our first in a series of webinars on evidence-based practices that are foundational to high-quality crisis care. Before we start our session, let's take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of our webinar. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled for our meeting. You can activate it by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please send a chat message to the host and my team will address that for you. Lastly, if you have any questions during the presentations, please enter them to the Q&A area. Those questions will be sent directly to the presenters and moderators. Next slide, please. I'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the U.S. Department of Health and Human Services, or SAMHSA, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. SAMHSA has selected Alterum to provide training and technical assistance support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W Consulting Corporation and Change Matrix, who have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system, one that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. We work to fulfill this goal through webinar series just like this one, as well as learning collaboratives, a yearly policy academy, more to come on that later, and through one-to-one TA services. If you are interested in TA services, please check out the link my colleague will share in the chat. Next slide. While our SAMHSA partners are unable to attend today, we extend gratitude to their leadership in supporting the TTAC as we collaborate with them to build a more robust crisis system. Jill Mays, the Division Director for Crisis System Transformation for the 988 Behavioral Health Crisis Coordinating Office at SAMHSA. She leverages her expertise built on over 30 years of experience in the behavioral health field. She has been instrumental in guiding the development of this EBP series. She's passionate about the work we are all doing in this workstream and extends gratitude to you all for your participation today. Next slide. In addition to Jill Mays, this series is brought to you by our small but mighty workstream team consisting of our lead Bree Carr, Behavioral Health Project Manager, Megan McGregor, Senior TTA Specialist, and myself, Jen Sedevi, Senior Consultant and Data Analyst. We are excited to launch this workstream today and are grateful for the time you are taking to join us. Next slide. The Evidence-Based Practice Workstream is a new initiative designed to bridge the gap between research and real-world crisis response. The series will feature interactive webinars focused on follow-up care and ethical decision-making, with today's session focused on establishing a foundation for understanding and building effective follow-up care systems. Through today's session, we will describe why timely, person-centered follow-up care is essential to effective crisis response, and how it impacts engagement, continuity of care, as well as outcomes. We will then examine the key elements that define high-quality follow-up care within behavioral health crisis response workflows. And we will describe common challenges to implementing follow-up care and explore practical strategies to overcome them, including challenges related to collaboration among crisis teams, behavioral health providers, and community partners. Next slide. By implementing EBPs in practice, providers can promote higher quality of care and better outcomes among those served across the behavioral health crisis care continuum. We are kicking off this series by focusing on follow-up care because follow-up care is not just a recommendation. It is a standard reflected in SAMHSA's national guidelines. Crisis stabilization models emphasize coordination of follow-up care and warm handoffs to ongoing services. and it is a component that should be planned for and occur at every point on the crisis continuum, as people who are experiencing a crisis need to have continued support and resources to ensure continuity. By training call staff to provide follow-up services, ensuring mobile crisis teams can identify community resources and supports to provide individual follow-up care, and coordinating follow-up care during transition from crisis stabilization, we can effectively embed follow-up care as the fourth essential element of crisis continuum and work to reduce the risk of repeated crises and build trust for systems and services. Next slide. Now, for the moment we have all been waiting for, today's speaker and their presentation on building effective follow-up systems. Next slide. Ariana Mellinger, founder of Recovery Innovation Consultation, a peer support consulting company, brings unmeasurable firsthand personal and professional experience to her efforts to shape crisis services and include peers in mobile response. She often speaks on topics surrounding mental health, substance use, and the criminal justice system. Next slide. Danielle Raghib is Crisis Care TTA Specialist with the Center for Applied Research Solutions. She has extensive clinical experience in crisis stabilization programs, is an expert in behavioral health crisis services, and supports statewide initiatives focused on implementing and improving mobile response services. Next slide. And finally, Josh Severance is a behavioral health and substance use disorder advisor with Kaufman and Associates, where he supports the design and delivery of community-centered and healing-informed constellations for tribal and urban Indian communities. He brings more than a decade of experience and regularly provides TTA to tribes, counties, and federal partners, emphasizing that person-centered, community-defined practices are essential components of effective and sustainable crisis care. We are excited to host this all-star panel of speakers today and hear their perspectives on building effective follow-up systems. So without further ado, I'm going to hand things over to Ariana, Danielle, and Josh.
Thank you so much, Jennifer. If we could go ahead and advance to the next slide. I know sometimes there's a bit of a delay, so thank you all for hanging in there with us. As mentioned, my name is Danielle Raghib. I'm a TTA specialist with the Center for Applied Research Solutions, and I'm really excited to be here this morning with you all and with my colleagues Josh and Ariana, who we've done a lot of work in several states around follow-up care, particularly post-crisis or after a crisis. And so we really are hoping today that we are having more of a conversation that really starts to shift in how we refer to follow-up care. And we're really hoping to kind of take some time to just talk about a reframe. Josh, Ariana, anything you want to add to that before we get started?
Not at this moment. I'm just excited to be with everybody, and I look forward to having the conversation with both of you guys.
Yeah, ready for the next slide. So, bonjour and dino magnadog. Hello, all my relatives. My name is Joshua Severance. I'm in rural Little Shell, Chippewa. I'm also Yankton, Dakota. I come to you in a good way today, and I greet all of you, and I invite you into our circle, our continuum in relation. And I think the talk that we have today, just to share, the core message is to invite you along, just as we invite those who we serve in the crisis continuum. The framing of this is, rather than seeing it as an aftercare, a point in time, that can sometimes get relegated to a check on a box. And so we really want to focus this on a relational approach for the continuum of care. It's sort of, rather than follow-up care, it's following care. And so I think our goal today is to really support and equip all the relatives here in our talk and beyond with this not only philosophical shift, but also in relationships. And we do that by sharing our stories and sharing what we know. And so I'm very grateful to join you all today. Pass it off to Ariana for her words.
When Looking at defining the shift of aftercare to the continuum, we also look at how we present to people as well. We look at how, what the words we use and some of the language that we use for follow-up care. Go ahead, next slide, please. And I'll pass it off to Josh on this one.
Yeah. So my PhD is in Indigenous and rural health. And so it has been ingrained in me to start with the justification of the need. And so one of those that speaks volumes is the high cost of how we view things in a fragmented, siloed system. And so not only the cost of health impacts, we know that post-discharge from any care facility or monitor care, when they are maybe further away in that care continuum from direct access, we see a lot of disparities. And conversely, when we see a closeness and a relational engagement of those folks on the continuum, we see fewer hospital readmissions, we see increased medication adherence. You know, all the research and literature and in the field is endorsed too, that we see a lot of better health outcomes, systems-wide, community-wide. And we know that when we're not talking, when we're not in relation with one another, whether we're in community, whether as care partners providing the care, when we have our scope and we're kind of set in our ways, unfortunately, the folks who may need help the most fall in between those, in the cracks. And so as a former firefighter and a medic, when I was training new recruits, I would say some of the most important work you do in emergency response, in crisis response, happens before the lights and sirens go off. So it isn't the clinical presentation and your skills when the lights and sirens are running. I mean, that's all very important, but it's how you are able to. It's knowing the route, it's knowing your community, it's knowing the schedules, it's knowing your team, and building on those strengths of one another. And so I think in the spirit of this talk and looking at the connected aspect, it behooves us to come together in a good way and have this talk. So I'm ready for my next slide. And
Sorry, Josh, I just want to also add, like, when we talk about the cost and fragmented systems, I think in addition to some of the things we'll bring up here today, you know, considering the human cost, right? Like, what is the cost to humans as a society when we have such a fragmented system, and when we focus follow-up care in a step-by-step process, right? We typically just hand people off over and over and over again. And there's never really this time to settle or time to connect that's, you know, in a way that's intentional and meaningful, because we're so fragmented and because we're moving so quickly. And so I think that is, you know, Josh talk about cost in terms of systems, which is absolutely highly important, but also the cost of like our human experience.
Next slide, please. As we speak about that, I reflect a lot. So my name's Ariana Mellinger, and I'm a person in long-term recovery, as well as a person who deals with mental health challenges. And there was a time and point and period in my life where I experienced the fragmented system, where the fragmented system really just helped drop the ball in my own life. And I thought, through years of like working as a peer support specialist, I think, what would happen if we had effective follow-up care, especially in the community that I came from. So whenever we look at communities, the community that I grew up in was a very small, very rural community. We all knew each other. We all knew each other and practically what everybody was dealing with. However, the effective follow-up care lacked. And a lot of the times it was through the criminal legal system, and then it was passing off people to the next place, whether it be through the bond system or through the emergency room, things like that. And so in my own story, it was the lack of follow-up care that eventually continued substance use and continued mental health challenges that could have been prevented at a very early time. This picture was taken of me whenever I had just turned 21. And so it wasn't until I was 27 that I was able to get effective care. And it was only through follow-up care that I was able to get linked to services. I was able to get linked to resources, which led me to later be a peer support specialist. So this is the important part of why we're here today and why we have these conversations. So I'm going to go ahead and say next slide, please.
Thanks so much, Ariana. I always appreciate you sharing your story and your experience. I think, just to reiterate, when we talk about the human cost, that's exactly what we're talking about, right? The impact it had on your life when you were engaged in a fragmented system that just kind of kept passing you along. But so happy that you finally got what you needed. So now we're going to shift a little bit, just continuing the conversation around traditional aftercare and post-crisis follow-up. So really just speaking to what we've done historically. So next slide, please. So when we talk about aftercare is typically defined as the care someone might receive during the healing or recovery phase, right? Like if you've had a surgery or, you've had some sort of event happen, then there's this aftercare process. Or for any long-term consequences of a disease, condition, or some sort of injury. When we talk about follow-up care can, it typically happens after some sort of service was delivered. In this, we're specifically speaking to crisis today. So after someone has experienced a crisis, we either call them on the phone, we might go out to them, we might send them a letter, sometimes text messaging, emails, things like that, who've recently experienced a crisis. And we're now trying to see how they're doing, right? What is their how they're now handling life. Are they at risk for going back into crisis? Do they need any additional supports? I would say a lot of the times we don't get back in connection with folks after a crisis, right? They tend, we might not be able to reach them, or if they're unhoused, we might not be able to find them again. And so that typically is like follow-up is the last part of, a service, and then we're done, we're moving on. And so we're really hoping to kind of shift that a little bit through our conversation today. And Josh, I don't know if you want to add anything here.
Yeah, and I think that's really well said. And I wanted to emphasize my experience in the crisis world is really grounded in as a former firefighter and a medic, but also as a tribal community member, as an enrolled tribal member. Just being a part of community and understanding that there's different layers of crisis, and knowing that if you're looking at things from that's not within my scope, or we've referred off, and we gave them a referral to XYZ and we sent our 2 forms of communication, I don't think that's as effective as we could be. And so for me, I know in my community, if I were to take that approach, the elders and the respective members of my community would hold me accountable for that, and it would also support me in supporting the community. And so ready for the next slide. And I think the focus on, again, follow-up versus aftercare and following care. It's sort of from a clinical lens. My crisis experience continued as a LCSW and a direct care provider and clinical supervisor. I think the keeping a pulse on things, keeping up to date on not only the folks who are experiencing crisis, but also those who are providing the crisis. The best practice of follow-up and recognizing that was a great start along the continuum, is saying, here's an acute episode, here's what we do to de-escalate and stabilize, and then we hand off to follow-up care. I think, again, it reduces a lot of risk for health disparities and the human cost of things. I also, looking at it from a timeline perspective, it is almost as if we're saying, oh, this crisis no longer exists. They are no longer a part of the continuum, or they're in a different part. We don't recognize that crisis exists to that person on a continuum. They may access the crisis. They may call 988. They may call a mobile crisis team at some point in their life. And so understanding that everyone is on the continuum, we're all sort of connected in that way, and how we coordinate that is really important. So how we think about it, the philosophy of that, also important. So I will pass it off to my colleague Ariana to talk or share anything you have about this.
I'm actually going to go into the next slide and talk about it a little bit there. So whenever we look at like that traditional view to the limitations and the preventative part of it is, as a peer and somebody who received it, is somebody sometimes might hand you that piece of paper and say, okay, here are all the services, now follow up. And the systems can be so big. You have to wait in line. You don't know how to navigate it through your job. There's so many other continuum parts of the limitations that whenever you're entering into the crisis, that life can be so overwhelming. Life can feel like it's coming to a stop. And so, therefore, like part of our role as the helpers in the continuum of crisis is getting people through that traditional view on to help pass the limitations. And I believe that's why peer support is so vital, is because they have that lived experience and saying, like, okay, where do we start now? Where is it that's number one priority? Where is it that we can follow up on what time works best for you? Well, what are your working hours? There's so many things that in the traditional view, sometimes it can be very preventative. So I'll pass it off to Josh to finish that up.
Yeah, I'm curious if we take an approach where I'm because that made me think of a lot of the work that Ariana and Danielle and myself have done in these series and the talks we've given have been focused on the mobile crisis, the MTAC Center in California. And that sort of brought about a lot of these really great conversations and just learning from one another, learning from community. And I'm curious, Ariana, your story is so powerful, and I always appreciate hearing it. When you think about it now as a clinician and you're providing direct care, it's almost like, what's your perspective on how that scope of, like, if you're an outpatient clinician versus a peer, how are you able to navigate those worlds, and how do you feel that they're beneficial, for, imagine both of them really help one another?
Mm. So, I mean, peers function in both outpatient and in crisis work, right? And so, sometimes having a peer in outpatient that you can do the warm handoff to, and it really helps continue that warm handoff that we'll later talk about, right? And having that person be able to say, like, okay, I know this person in outpatient, and I can introduce you to them, and then be able to hand them off through the crisis, to be able to say, this is somebody who will help you navigate these systems in outpatient setting, versus I'm here to help you navigate the systems in crisis settings. And as a person who received it, as far as like never getting to receive services, I think that's a vital piece, because in that beginning part, whenever the ball dropped, right, I didn't know how to navigate them myself, and they become overwhelming. They become like, how long am I going to be here? How long am I going to have to wait to be seen? And then each system is different, so it becomes overwhelming for the person, possibly sometimes preventing them from continuing services or from even starting them to begin with. Oh, I have to wait for, in my community, sometimes it's up to 3 months for psychiatry, versus another community that I used to work in Houston, like you could get it the same day. So there's just so many different limitations that we can prevent as crisis workers.
In EMS, we have a concept. It's called implied consent. If you're rolling up on your ambulance or you're rolling up on scene, there's an implicit level of consent that happens when somebody's incapacitated or they're not able to sort of advocate or access their own safety or their own. And so it's almost like being a peer and you having those lived experiences and that lived expertise, it's almost like you have this implicit level of trust where you're not only aware of what it's like to have gone through the care system, but also now providing the care. You're able to really provide the depth in walking them through that continuum.
Absolutely.
I think we're ready to go to the next slide. And so we, Josh and Ariana were touching on this. And so we have been working very heavily in the crisis world in terms of mobile crisis services. And so when we think about an individual and when they're in a crisis state, it's very similar to what Ariana was saying, is that this is typically a time in someone's life when, we all go through crises, so we've all experienced it, when we have tried to manage whatever's happening in our lives, the stressors, situations, and it's just exceeded our ability to cope and to manage in the ways that we would normally. And so we tend to feel desperate, we might spiral, and things just feel unmanageable. And so when we talk about follow-up or aftercare, when we kind of through the traditional lens of what we've done, we're implying that something has already existed for people, right? We're implying that they already had a pre-existing support system, whether it be through family, friends, services. We're implying that that already exists, or that they even know how to navigate a system after a crisis. And so what about those who don't have existing services or don't have existing support systems? Or what about those who, being in crisis, as most of us are, aren't ready to cope and manage with the overwhelming system that follows a crisis to access continuing care? Which is possible, right? We look at evidence-based practices and all the research that tells us we should follow up in this amount of time because it's the best time to keep people safe, which is great and true. We know this to be true. But also, what about that practice-based evidence, what we know works in the field in terms of going out and providing that support to someone who has experienced a crisis, who might be feeling very overwhelmed, feel like they have no support, and then to just give them a paper or to only call them once, that can be challenging, right? We're not really supporting that continuation of care. And so this is why we're really hoping that we can shift away from associating follow-up care as like the end of a crisis service, um, and more towards seeing it as this opportunity to really engage folks into ongoing continued care, and that when they enter the crisis continuum, that it's not this, okay, the door's open, you're going to go through these steps, and now you're going to exit this door and be done. It's more about, we're always going to be here because we're always going to experience crisis. Like Josh said earlier, we're all on the continuum at some point, and it just flows as it should. And so, Ariana, I saw you come off mute.
Yeah, absolutely, because it makes me think of the language like case closed, closure and things like that. Like whenever we reframe that language as far as like if we're helping an individual, like we'll see that individual within our community if it's in a rural setting. We'll see that individual through warm handoffs and hopefully later on in our community. Maybe not in the same exact way, but we'll get to see them hopefully continue their care and know that like, hey, they've been successful at wherever their reintegration wants to happen. In my own life, I didn't like what you're saying. I didn't have that support system at that time. And so therefore, like if somebody would have had follow-up care questions for me, like, hey, what does your support system look like? I would have been like, what? What are you speaking about? So there's those questions too, like how do we effectively come at care and what questions are we asking during that time?
Yeah, absolutely. And I think as we're moving into this kind of building the pillars across the continuum and the importance of follow-up care and the importance of continuing to engage folks. I also want to acknowledge our system is impacted, right? Like I was previously a mobile crisis provider, and so I know how much pressure and how much volume we face on a daily, and then the lack of resources and the lack of system support makes it harder to do our job. And so I also want to just acknowledge that sometimes it does become a checkbox because that's all we have to give. Next slide.
Yeah, great points made. And I think the continuation of care, it sort of looking at the three pillars of the crisis care continuum, of somebody to call, somewhere to go, and someone to show up. This is sort of the spirit of the golden thread that we weave between all of them. It's the continuation of care in accessing all of those services and having them connect and in support of those experiencing crisis. I think of if someone, goes through their whole life and they have not accessed formal care in the sense of outpatient therapy, or they've not called a crisis line before, maybe they work in direct service, and something happens in their life and they reach a point where, one way or another, whether it's through law enforcement involvement or 988, they get involved, and that in that point of time is sort of their start to care. So they've been pre-elevation, meaning that they're still on the continuum, they just maybe haven't been directly connected with. And so once they reach that spot, sort of the no wrong door approach, they are then sort of, we see you and we have you and we're here for you. And we being those three pillars, and how we, in the spirit of that, connect is that golden thread that weaves us together. And so again, that's really driven by relationship and recognizing that care, whether the first time they call 988, first time they call a mobile crisis team, first time they go to a crisis stabilization unit, that is the start to their care. And I guess every care after that could be defined as aftercare, but we have to look at it as continuing that care. Even if they are stabilized and they're supported in their community, they're still on that continuum. There's still that potential to be active in the care continuum. So I think recognizing that philosophical shift and recognizing how we talk to one another, it behooves us to come together and coordinate these things for a variety of reasons. And the most important is the human condition, the human aspect of how this, why we do this work. So I will pass it off to my colleagues if there's anything you'd like to share on that before we go to the next slides.
I just really think that you have beautiful language around that. And I want to recognize that for the first part is like that relationship building piece within the community, whether it be through the ambulance system, whether it be through the ER system. That's the key piece of being able to do the warm handoffs, how it is on that slide, because you have that relationship with somebody to be able to say, "Hey, I'm bringing in somebody today, and will you be there? Will you be working? If not, who's working today? What is their name?" And then that way, I can tell the individual, "Hey, instead of this person who we thought we were going to meet, we're going to meet this person." So it's within those relationships.
Mhm. Agreed. And I think we're ready for the next slide, please. All right, we're going to move on to talk a little bit about best practices and strategies for continuing care. And this is based off our own practice and our own field work and what we've done in the sense of mobile crisis services or as practitioners, and also in combination of what we know, in terms of evidence-based practices that work in the field. And so next slide, please. Sorry, I keep forgetting that I have to say that. And so we're going to talk a little bit about a structured approach. And so why is a structured approach crucial? When we talk about a structured approach to aftercare or follow-up, or continuing that care, which we're hoping to move towards that language, it's that we're not just checking boxes, right? Although we acknowledge that sometimes that happens because we ourselves don't have what we need, but instead of checking boxes, that we're really working towards providing that very comprehensive, consistent care that can be measured and improved on over time, and that we're also working with individuals in a very customized way, because what we do know is that the same approach does not work for everyone, right? So if we have a structured approach, that's great, but we have to also adapt and be flexible to individual needs. The components of structured follow-up include, some predefined checklists or protocols. So what do we know works? What do we have available? scheduled timeframes, designated responsibilities amongst your different team members. And this is not just about your organizational structure, but also within your teaming. It ensures that all follow-up sessions happen in a timely way, and that they're very individualized to that person's needs. And I'm going to hand it off to you, Josh, to talk a little bit about the monitoring piece and the components.
Yeah, thank you, Danielle. The concept of care traffic control is sort of a theme that I think about when we look at the structured approach. And that recognizes everybody's strengths, everybody's focus. If you're looking at mobile crisis, you're looking at dispatch times, you're looking at reach, you're looking at penetration, you're looking at coverage, and depending on the structure in your state or your county, there's certain metrics that are important. And then also, clinically, if you're looking at things, there might be a higher incidence of suicidality, or there might be a higher incidence of SUD or substance exposure. That really helps to inform your service system. And in looking at things from all pillars, it's sort of the care traffic control. And that analogy isn't perfect because we're humans, not airplanes. But if you look at it as an airplane, the surgical, technical nuances that an air traffic controller uses to guide that aircraft to where it needs to be safely, and is aware of the atmosphere around it, the weather patterns. It's similar to the fact that you're looking at somebody experiencing crisis, or they're involved in the crisis continuum. You're recognizing the different factors that may be impacting them, in their journey. These, down to a more granular technical level, we have kind of ways of thinking and ways of speaking about things from a technical aspect. I know EHR systems and dispatch systems, a lot of them now are adopting what's called FHIR protocol, which is fast health interoperative technology. Basically, it's the ability to talk the same language, so that your EHR can talk to an EMS system, so that your records can be shared seamlessly. And so those kind of structures have to be decided upon and built by the hands that are serving in those different capacities. So I know that it looks like there's a question, so I'm curious if our moderators would like us to hold off, or if you want us to continue on the.
We can hold off for the question to the Q&A section.
Great.
Thanks.
Ready for my next. Hand it off to my colleagues.
Yeah, so now we're going to just look at some strategies for staying connected. So when we talk about staying connected, we're talking about that continued follow-up care or continued care. And so these are some of the things that you brought up, Ariana, that I think are really important. And I've seen these be very effective in the field when working with individuals, is letting somebody know, or that family know, that we are going to support them and we will be there with them alongside through the next steps of continuation of care. And so it's important to be transparent, right? To lay out the next steps for folks so they know what to expect, but also let them know that I'm just laying out the next steps. These things aren't happening right here, right now, and they don't need to happen, within 24 hours, but this is what is potentially going to happen. And so when we're transparent and we're upfront with folks, it gives them an idea of what's next. We all love to know what's next, right? Human beings love to know what's next. We like certainty, and we like to be able to expect. And so when we get uncomfortable is when we don't know what's going to happen, and when there's too much uncertainty. So we can provide relief in that sense of, this is what is potentially going to happen, and this is what I'm going to do, or what someone from my team is going to do. And like Ariana said, those names, who's going to be there, I know this person, this is what they do, this is their name, and this is who you're going to be talking to, kind of thing. And so we talk about emphasizing that very collaborative approach. So this isn't something we are telling to them, right? You're going to do these things and these things are going to happen. This is something that we're doing in collaboration with. These are the things that we can support with. How do you feel about that? What would work best for you? How can we come and connect with you? What time do you have? What's the best approach for us to come back and talk to you? And so it's asking people what works best for them and making sure that we're honoring their voice and choice. Ariana?
Absolutely. Because I think about there was an individual where I got to work with, and she told me very, very upfront. She said, "Hey, if you call me, I'm probably not going to answer. However, if you text me, I will answer." And so we did hourly check-ins during my shift, and I said, "Okay, well, during the hourly check-in, how would you like to check in?" And it was literally just a thumbs up emoji. And so she would just be like, "I'm good." And I would say, "Okay, I'll hear from you at this time." And so it's like creating those safety plans that are creative enough for all individuals of all spectrums of all ages as well.
Mm-hmm. Yeah, I think one of the biggest things too is oftentimes we tend, and I'll speak from my own experience, we tend to make promises, right? Because we want to do these things. We want people to feel like they can count on us. And something will happen when you're not available, right? Like you have made a promise to someone, you've said, I'm going to call you at this time, or I'm going to come back at this time. And the universe was like, nope, you're going to be over there today. And so it's making sure that you're checking in with that person. Hey, I know I said this. Is it okay? Can we do this? Can Ariana go? You met her. She was out there with me. Is it okay if she comes out and talks to you? So just being, again, transparent with folks, and if you're going to do something, try your best to do it. And when you're unable to, let them know and give them a reason.
Absolutely. And I also believe like when you have scheduled time off too, like you let them know ahead of time, like, "Hey, I understand we have the 24-hour check-in. However, I won't be there today, but my colleague will be. Is that okay with you if that's who you check in with? Do you prefer somebody more presenting in male, or do you prefer somebody more female?" These are the things in the conversations that you ask as far as like what are your preferences and who checks in with you because of trauma histories and things like that.
Mhm. Yeah, and we tend to focus, and we're going to go into this a little bit, on making sure that someone is continuing to be safe in the community, right? And so we're monitoring for that ongoing safety. We're checking in on that ongoing safety and that safety plan if it was developed. But the other thing is, like, are they feeling safe with our presence and what we're doing and what we're hoping to do with them in a collaborative way? And it's okay to ask that. It's okay. Just like Ariana said, like, if I can't come out, do you prefer? Is it okay if one of my colleagues comes out? Is there someone that would make you feel uncomfortable? And having those conversations, that's safety too. Next slide, please.
I think touching on that, finding and connecting with folks where they're at, and the younger generation, whether it's through text. And I was thinking, like, you know, in the era of TikTok, the multimedia engagement, the opportunities for those types of media interventions are plentiful. So we live in an era where as clinicians, we can be really creative, um, in best serving and communicating with the needs of our relatives we're serving. So from a care standpoint, I think and it looks like there's some questions and considerations about systems, use of systems, technology for systems. And like I said, that care traffic control model of how we're looking at coordination and referrals, and even things like consent, and setting up those memorandas and those kind of agreements beforehand, so that when the person in crisis, comes through your doors virtually or physically, you're able to support the continuation of care for them. So it's something that I think is really an excellent, that I've seen a lot in the field of epidemiology, is basically live feeds. And I know California has has an incredible system that looks at bed utilization and crisis stabilization availability. I know also regionally there are technology platforms, and I'm not endorsing any specific one. I'm just saying the fact that you can see the availability of crisis teams, you can see their location, you can see their capabilities in real time. I think that equips you better as a system to sort of support the care of the folks in crisis. For a firefighter perspective, I think it's called mutual aid. and maybe we don't have a helitac crew, we don't have a helicopter crew in our region, but we need one. And so we have, we have those relationships built before the fire starts, of course. We don't want to be trying to make buddies with somebody with a helicopter when the fire is already going. And so being able to have the technology to say, this helicopter is available, and in this case, this mobile crisis team is available, they're in the area, or crisis stabilization unit has availability. And then you're more able to endorse and use the care and the services that are available for you as a partner in the continuum. So I'll pass it back off to you all to continue talking about that approach.
And I'm going to go ahead and actually go to the next slide to continue the conversation. So whenever we look at those things and we look at just the way we share technology and the way we go into it, building the connection for the continuum of care, we're really looking at the importance of like ensuring safety and ensuring coping skills. And that's a lot of the times why people are using the EHR systems. I can say in my own experience when working in Houston, like we could see in real time, like Josh was saying, is if a mobile crisis team was being transported or going on a call to the person, we could see it in the EHR system and we could know that's why the person would have missed their appointment, things like that. And so those things are also important when you can see their care team, things like that, because when you can see their care team, you can follow up with the individual with permission by saying, hey, I see you missed your appointment today. We're here. What occurred? What happened? And creating that and part of building in their safety plan and building in their coping skills and creating this list of saying like, okay, like was it mismanagement as far as like time? Those are the things that you can help with the individual as a peer is creating those plans with them. Pass it off to Danielle. You're on mute.
Sorry, thank you. It had to happen at least once, right?
Right.
Uh, yeah, everything Ariana said, absolutely. And just making sure that when we're connecting back with individuals or families, that we're just really instilling again that hope that things will get better and can be better. Because that's a crucial part of supporting someone through a crisis and supporting them through the next steps. And so the way in which we ask questions, the way in which we connect folks, right? And the way in which we honor their voice and choice matters, especially in this process of connecting back with them and making sure that we're working with them, walking alongside them on that continuum of care. Next slide, please. And this feeds a little bit into when we're checking back in, especially in terms of supporting their ongoing safety when we've responded to someone who might have experienced a crisis where there's some safety concerns. And so we tend to want to revisit that safety plan, right? We want to ask if they're doing what, the things that were identified, if it's working for them, and if it's not working, how can we then support them and collaboratively help them develop something that would actually work for them. And we can't expect complete change over the time frame of 24 to 72 hours, right? And so we want to also remind folks and ourselves that change takes time, right? And so if we've identified something and it really feels like it's not working and that it won't work, then we can have the conversation of how can I support you in replacing that or finding something more helpful for you. And just making sure that they have access to it and that they are able to utilize it. And sometimes, safety plans don't work for everyone. We know that. And so making sure that we are asking those questions during that, re-engagement when we go back and when we talk to them, and if they want it on their phone, if they want a printed copy, making sure that we're honoring the way in which it works for them.
Right.
Ariana?
I think about an individual, a young person that I got to work with, and she said, I want to try and do TikToks. And so there were TikToks, and so I followed up with her later on, and I was like, okay, so how are the TikToks going? She's like, yeah, no. She's like, she thought she had to continuously post them. And I said, you can store them and keep them there. You don't have to post them. And she said, oh, I didn't think about that. And it was just a creative outlet for her that was part of her safety plan, that when she felt unsafe, she could get out and use movement inside of her body. And so she would do dances, she would practice, and then she would just save them. She wouldn't have to post them or things like that. So sometimes it's a little tweak, sometimes it's a whole creating a whole different coping skill of saying like, okay, let's try it and shift a little bit different.
Yeah. Next slide, please. And so when we are, working back with we're connecting back with someone after that initial engagement, we are also, when we're looking at, their ongoing safety and the importance of, are they still at risk? Have we reduced risk? Are they in need of additional care right now? Some of the other things that we're looking at is identifying additional resources and supports. And so we may have already identified some supports for them during our first engagement with them, and those might not have worked, or they might not be available. Ariana talked about long wait lists, and I think that that is pretty general right now, right? That there's a long wait list for services across the country. And so considering what else is out there, what additional resources and supports and connections can be made to ensure this individual stabilization. And when we're talking about continuation of care in this sense, we're talking about folks who typically who remain safely in the community, right? And so we're looking at what things can they immediately access. And oftentimes we think about, therapy, psychiatry, some sort of other connection to intervention and services. But what about basic supports? What about basic needs like food, housing? Some of those, having the lack of those basic resources can put us into crisis, right? Or can also be so stressful and overwhelming that we could tend to go back into crisis more easily or quickly. And so we want to make sure that we're also offering those connections and we're asking those questions. Legal services, things like that. And it's important to support people in a collaborative, like we've been talking about, in a collaborative way that really supports problem solving through those barriers and obstacles that might have been identified in terms of them accessing services, because sometimes there are barriers to care. And we want to acknowledge that and be transparent about that. And we want to support them through those barriers. Sometimes people decline clinical intervention, right? Or any other support, and that's okay. But they may be open to different types of supports, like food or peer support or other linkages that might be available based on their individual needs. Ariana?
I just think so there was one situation where I had this very evident that I worked with an individual. The individual really wanted to work in their own life, and he was 17. So he was able to work and go there, but his parent wasn't able to help drive him there. And so we navigated what looking at the bus system looked like, how to get on it, how to get off of it, what the routes were, things like that is just being able to support people and how to navigate the services. These, even something as some people might say, it's simple. Riding the bus in Houston is tough. I know in other places they don't even have bus systems. So, like, if you're new to the area, you might have never even navigated that before. So there's just many things on how to access food banks, like what documents you need, things like that peers can really help with.
Yeah, I think we're ready for the next slide. And I think colleagues, we need to speed it up just a bit, just because I think we're running out of time.
Yeah, just going off the points you both were making about getting our relatives connected to those resources. It's not that we have to be the expert at everything and know how to access the bus line and navigate, but we have to know the people that do. And that's where the relationship comes in really, really important. So we have to have those coordinated agreements. I think knowing formalizing it in whether it's an MOU or MOA or other form of documentation. I think that also can provide a way that structures automated notifications, like if someone's being discharged from your crisis receiving unit or crisis stabilization, informing the relative patient that follow-up is going to happen, and coordination with 988 might happen. And again, that work has to be done before the care happens. So I think that's something that the systems need to sit down and say, this works for us. And in the fire world, again, it's a mutual aid agreement. So saying anybody that's discharged, there's a high risk. Anybody that, if we identify food as a need, we're going to coordinate continuing care with the food resources that we have. So again, just relationship driven and really supporting that effective transition. So ready for the next slide. I think that actually brings us into the next piece about peer support, which is the inherent relationship that provides that, easily drive that coordination. So ready for the next one. I'll hand it off to Ariana.
Absolutely. So peer support is in part of many different parts of the crisis continuum of care. They can be in 988 systems, they can be in many of different places. And so for me, where I really got to utilize it is inside of a mobile crisis outreach team. And just like what we've said over this time in the presentation is how effective it can be, how effective how it builds rapport, how it addresses workforce gaps, and how it uplifts recovery orientation, including my own, to get to see others and see them grow in what they want in their own autonomy. Next slide, please. And I'm going to pass it off to Josh.
Yeah, thanks. This is my doggy, who's no longer with us in the human world. But this is an example of kind of like the text updates, keeping connected with the folks that we are serving. So this is an example of what's called a caring card or a caring contact. And this was done by our local tribal community. And it is essentially just a postcard that was automated, that is automated to be sent out to somebody that was flagged in our workflow as experiencing a certain score on their PHQ-9, and then any positive scores on their Columbia. They automatically get one of these. And everybody gets one of these if it's your birthday. If we have a known anniversary of a passing, when I was doing direct care, that's sort of the how we did that. And we came together as a community. There was a photo contest that happened. I was encouraged to submit a picture of my dog because he's Kuzu, was his name. It's very, love that guy. But he was selected as one of the photo contest winners. So he was pretty proud of that, I think. But just an example of how, and of course, pictures of, in our tribal community, of our youth in regalia, really meaningful pictures that people can connect with. So I think a goal of aftercare and continued care is to get people connected to something greater than themselves, something bigger. And so a visual image and just the thought that somebody's caring, wanting to connect with you, that was something really, it's been proven very beneficial. So go ahead and ready for my next slide. So again, the transitions can look in supporting our in supporting our relatives, whether it's a handwritten postcard, whether it's a text message, whether it's just a phone call that does not have to disclose any PHI. Again, those caring cards don't say anything about the fact that they were seen for suicidality or that they were flagged for risk. They are just sent out just to make us, just to remind folks that we are connected and we are thinking about them. And that's a very powerful driver. We send it to a lot of elders. They request them. So that's something we've found really important. So though the messaging and just the relational layer of being in community. When I was providing direct care, I mean, I had to provide that in my informed consent in my OPC. Like I'm a behavioral health clinician from 8 to 6, and then because they would see me at the store with my son, in my slippers, and we'd be getting breakfast at the tribal market, and but I was still me. I'm still who I am in the community, and I still care. It just maybe changed the way that I was able to care. I wasn't going to open up, a crisis support session right there in the line at the market, but just communicating that, in these different ways, these different capacities, here's how I can help. So I think being part of community is really being part of community and in relation, not only with the people we serve, but with each other in service to our relatives experiencing crisis. That's kind of the spirit of what we wanted to share today. So I think ready for the next slide. And if Ariana or Danielle, you want to add anything to that, please.
Yeah, I think Josh, we've had these conversations before, is a lot of this kind of, often feels like these emerging practices, right? Like this new and upcoming thing that's coming. But if we look at our communities and what our communities have always done, we can learn a lot, right? Like Josh just shared, and everyone in the chat is chiming in about those tribal community lessons. Like, what can we learn from those communities to just show that we care? When we talk about supporting people, individuals, families, we're really just showing that we care. Those clinical interventions are key, they're great, but when we're talking about connection, that connection is that humanness that we bring to it and what we know works in communities. So look at your communities and investigate your communities to know what works in those communities. How do people feel served and appreciated and loved and cared for in those communities? That is the most important thing we can do.
And coming at it with just care and connection and showing through language, through everything in through body presentation and how we show up. Even if it's like having some time and saying like, hey, I need to take some time because I'm not showing up well. So things like that are all key aspects of follow-up.
Mm-hmm. And we just want to kind of close it up a bit in terms of some of the key takeaways today. And I think the biggest thing is just show up and be a human being with your fellow human in crisis. And, just that ongoing support and that presence is sometimes that biggest thing you can do, that biggest intervention you can do. I often talk about sometimes just listening as being the best intervention you can do in that moment is just listen to someone. Peer support specialists bring a very unique skill set, right? And they bring their own experience to the work, which allows for deeper connection. And so we want to honor and acknowledge that work, and how important their work is and their service to the community. And that a continuation of care really focuses on meeting people where they are, and that we are constantly working on improving outcomes and supporting that linkage to additional support as needed, based off those individual needs, and that we're shifting away from this being the end of a service more towards this is the beginning, right? This is how they're now accessing services, and we want to establish a really healthy and strong relationship from the start. Josh?
Yeah, I think all of those points, and it makes me think of the work and kind of the journey that us as a team here, Danielle and Ariana, we've been part of this incredible. It's not novel to us who are in the field doing the work. We know what has worked, and so to see this shift now, it is not a new novel. It's just now being endorsed and affirmed and recognized. And as an enrolled tribal member and a tribal community member, to see this relationally focused, community focused emphasis is really affirming. And it affirms that when you support people in their community rather than the extractive nature of a lot of crisis response, we have better outcomes. It's better for everyone. You get family involved. And really, in the spirit of that is the peers, lived expertise in elevating that, because as clinicians and as administrators, I think we have ideas of policies that work, but really until we listen and have that voice ground everything from policy to operation, we miss out. We miss out on a lot of the wonderful medicine it brings. Just wanted to share that.
I also say that it helps bridge the gap from clinician to peer as well. And with that, I believe we're on to our next slide with references.
And we can go to the next slide, please. One more. Thank you. And we just wanted to say thank you all for sitting here with us and listening to us. And if you would like to get in touch with us, this is our contact information. Feel free to reach out. We'd love to engage in conversation with anyone, and appreciate you all spending your very valuable time here with us this morning. And I believe we're going to hand it back to Jennifer.
Yes, thank you. Excellent presentation. Really appreciated setting the foundation in terms of the reframing, because really how we're thinking about follow-up, how we're speaking about follow-up is going to be important for how we're going to be carrying out follow-up services across the continuum there. So I really appreciate grounding in that message, as well as just continued thinking about how we do this work and how we collaborate with our communities and those we're serving and other parts across the continuum as well, throughout all of the pillars and various services that are being provided.